gonna go for sharing. So as I said that we have two topics, so we're gonna have around an hour and a half for covering both topics there. So let me go for the share. Okay. So the first topic is the suction tube dilatation, and the second one is the valve. I'm gonna start with the small presentation regarding to the valve. Can everyone see it there? So I'm Mr. Ibrahim, the ENT consultant in Lincoln, and thanks Professor Ali for coming today and cover this topic. So, as you can see, he is a funny guy. So this was a kind of a meeting that we've done last year, the ENO. So we're gonna go very fast through what is the valve, what is the anatomy, how we can manage, why we pick up the Latera as well. So generally we have two nasal valve, a small one in the front called the external, which is not the main, and it's the one internal. And this is, the valve means the narrowest part of the nose. So if it's very narrow, it will lead to more obstruction and symptoms. If it's in an inappropriate position, it works well and the patients can breathe in. Why we need the valve? We need the valve to get a bit of a turbine inside the nose so we can feel that that we have resistance inside the nose. So we have external, internal. The internal is the important part, and that's what the Latera will treat mainly. So it's like what you can see, this is like a triangle there. We have the septum on that side. We have the lower lateral cartilage, and we have here the floor of the nasal cavity with the head of the inferior turbinate. So those are the valve. So if we need to do any work around for the internal nasal valve, we need to either to correct the septum, push this lateral wall or the lateral cartilage, or shrink the anterior head of the turbinate. Sometimes it's the cause as well. Externa does not really contribute much with the resistance, but we can see a lot of people have a slit like nasal opening, and at that time we can't help much, to be honest. Sometimes the septorhinoplasty, which is the big surgery, will be the possible to treat those types of valve issues. Okay, we need them mainly for exercises, so to widen more during exercise, but nothing more than that. So what is the nasal valve? What can the nasal valve can do? So resistant nasal congestion, yes, the patient feels the nose is blocked, cannot breathe through the nose properly. Also the nasal obstruction sensation because there is no much of a turbine of the air inside, despite there is a good air. Snoring sometimes, yes, if there's a much collapse, especially when the patient takes his breath in, the collapse will get more in. Words, also whistling, yes, I've seen it before, and the visible collapse when you examine the patient. The causes, a lot of causes. The most common cause is the trauma. So traumatic and usually accompanied not only with the lower lateral cartilage, the weakness of the cartilage itself, comes with the septal dislocation. So at that time, you need to address that as well. Or patients have kind of born with that, congenital anomalies with the weakness. And usually this is persistent symptoms for a long time. As well as we find that the children, they have adenoid for a longer time as well, because they try to sniff in more. So they find this type of a weakness of the valve that happens from the sniffing in. Inflammatory conditions, as we know, the allergy can be a cause, and it's usually obstructing the anterior head of the turbinate. So whether we need to do something with the cartilage themselves, the septum and the inferior turbinate together, this is need an evaluation. So back again to the evaluation. Sorry. So evaluation simply to assess the valve. It's Cottle. So Cottle is a maneuver. They can do it with your hand. Push the cheeks to the lateral and ask the patient to breathe in. Okay. Or getting a small spatula or the Jobson horn things, and you push it inside and see whether the valve is working or not. I like the modified Cottle more than that one because sometimes when you do this, you will assess the internal and external, but the modified one only for the internal. So at that time, we decided to go with the Latera. So treatment of the valve problems. So started from the non-surgical bits, and you can see a lot of things that in the market, like these strips, the nasal strips. There are new ones with the magnets. I find it amazing, and as well as that, I use it to test the patient with as well. It's not nice because you get a lot of plastic and adherent materials on your nose, so you get a lot of inflammation in the outside. So the patient who uses it every day, you find there's spots on his nose there, so it's not nice as well. So whether he needs a definite or not, so you can try it as a trial. Going for surgical treatment, as we said, plasty itself can help with the valve if you have a dislocation or any kind of anterior deviation. But it's not the only solution. It have to be combined with the rhinoplasty or the non-invasive things like what we use, which is the Latera. So what is Latera? Simply, it's a kind of a material that can be absorbed by the body, and it's a supportive things. We can implant it inside the nose, under the skin, and it helps to push those cartilage and prevent them from collapse. I'll talk about how we do it in a minute and how it works as well. But as I said, you have to get appropriate assessment for the patient that he's suitable for Latera only, or he need a tapered surgery with it, or he need a septoplasty with it. We haven't done much here because it's new, so we have done 4 of them. One of them was pure Latera, and at that time we didn't need to put any packs inside the nose, and the patient was very happy after, even in the recovery there, which is the 3 of them have accompanied with one of them with the tapered surgery and 2 with the septum. So, as I said, it works with itself. It's yes, but you need to have appropriate picking up of the patient's work by itself, so you can do it on the local. Haven't done it on the local up to now, but this is the plan if the patient needs only to be done on the local. So back again to this is the implant, which is that material. Not quite sure about what it's composed of, but what I understand how it works. So it works with inducement of kind of inflammatory process, and this inflammatory process ended to macrophage to come, so it will be encapsulated, and then the macrophage, when it comes, it will eat these materials and deposit some of the collagen, new collagen, and that will make the strength of it. How long it take? They say it's up to 24 months, but myself, I've seen the first patient, which is now 6 months, and actually I couldn't find, I can feel it, but wasn't the same as previously. So it could be a patient to patient as well. So because the paper said that it's from 18 weeks to disappear to 24, and you can start it to be dissolved after 6 months. So it depends, to be honest. Trishna will answer these questions. Nobody asked me. As I said, we haven't done it for long. It's now 6 months. Is it correct? 6 months. But to be honest, myself, from the patients, I'm very satisfactory with them. As a patient themselves was happy as well. And as I said, I don't know exactly whether it's the Latera itself by itself or the other surgeries, but anyway, it works. It saves us to do a septorhinoplasty for a longer time, and actually Latera takes 5 minutes to 10 minutes each, so 20 minutes. So you don't need to do like 3 hours work with the modification of the cartilage. So simply, this is the implant. We're gonna have a look in how it works later on hands-on, so I'm not gonna go into the depths of it. And this is the package of the implants themselves. So we have a needle, like an introducer, and the implants. Okay, so I think so. This is the lecture itself. So we have 2 videos. I think so. What we need to do is that this is the preparation one. Is that the preparation?
And she has significant problems breathing through her nose. What I would like to do today is talk to you about the use of Latera, which is a product from Spirox, which can be placed in the lateral wall of the nose to aid in lateral wall support. When she breathes in, she has difficulty breathing through both nostrils. And so what we typically do is we'll put her head back here and I'll watch her breathe. And what you see here very clearly, breathe in again, is you see this whole sidewall of her nose move medially. And what that means is there's weakness in the lateral wall, it's collapsing into her airway and blocking it. So what we're going to do today is basically insert Latera, which is going to go in here in a subcutaneous layer deep over the bone to about this point. And what that's going to do is cantilever off the bone and basically create support to the sidewall and improve her breathing. So I can go ahead and I can place.
Okay, so this is how to assess, and you can see it's not that of a difficulty, and he used the Jobson horn for that as well, which is the modified cut. And he do it as office base. I have one of the videos. It's not that clear.
Today we're going to do a demonstration of Latera on the head model.
So this is the head model one. So we're going to have a look into the head model one. That's what we're gonna do. I may kept it to the end so you can review it beforehand. Is that okay for everyone? So we can go. I'll show you the video how we do it, and then this one will be to the end before hands-on. Is that okay? So you will know what is especially for our colleagues from the theatre. Okay. So this is the actual surgery. This is me doing it. I will go through it very fast, so you're not gonna go for details because details will be on the head models one as well. Okay. Bona, he was the cameraman. Is it? He was the cameraman at that time. Was it you? No. Okay. I forgot who was the cameraman. Anyway, so so simply what we do is that, because I'm gonna forward it very fast as well. So we mark the areas that we need to put the implants in it, and usually we measure the heights of the nose, so from the ala to the tip, and it's midpoint. So this is the area that we can put the implants there. Laterally, what we do is that we come to that way. I might leave the video to run through. So already I've done the marker, so sorry for this, but I will show you laterally how we market it as well. So this is the actually like a demo of the implant. So you know what is the direction, your direction of the implantation, and in the same times you can put the points that you're gonna for your marking points, which is the top and the end of it. It will come in the lateral there. So we have a top marks and a lower one as well. The top one is just over the midpoint of the nasal bone, and it's similar to with the line of the heights midpoint between the ala and the tip of the nose. The second one, you're gonna see it again here. So I mark the bone and I mark the lower lateral cartilage as well. Okay. So the same. And now where is it? So the first one will be just at as I said, just above the lower lateral cartilage, and the second one is in the midpoint of the nasal bone. So it will be supported with the nasal bone. In head model one, you will see it more clear than this one, to be honest. This has been filmed with the camera of the scope. Sorry, we didn't find the actual camera for the theater. That's why. So local, so you just inject the area that you're gonna implant in or introduce your trocar in. Up to the bone again, the other side. And then this is the introducer, okay? And the way to open it and close it, we're gonna practice on it anyway. And we're gonna show you. So simply you're gonna pick up one of those implants, okay? One of those, okay? And just put it here. And simply to open it, there is in the back of this introducer, there is a button to open the introducer. Once you put it in, put it back, and there is 2 clicks. The first click is just to make sure that your implant is now in the needle, and the second one is when you release it in. And then again, and you can see how the valve collapsed in this lady, and you will see after. So the pivots will be towards the skin. So make sure that the pivot is toward the skin there, okay? And it's 90-degree down, and then turn around and up in the direction of the bone and the cartilage. Once you're in, you just release it. And there is a guide at the end of the introducer, which is those. So those should be in the same direction of the nasal valve. I'll tell you in a minute. When we go to the hands-on, this will be more clear. And then you release. I'm going to show you the other side. Yeah. The same way. So you go in. The pivot is toward the skin inside there. Okay. 90-degree towards the septum. Go around and then reach until you fill the end of it at the top marker. And once you're in, you just push the button. This button, the lower one is mainly for to open it and close it. The second one is to release, which is the big one. Now, once I'm happy that we are in, yeah, and my direction is correct, I'm gonna push the button in. And if I'm a bit doubt of the direction, I have this kind of lead to tell me where am I and what is the right direction. Okay. And now fix, release. Once it's in, make sure that you are supporting the upper bit of it, and then you can take the introducer outside. Okay. And you can see the internal nasal valve from what it was almost touching the septum. This is without any force, anything there, and it's very, very nice and support. Despite she have a lot of very collapsing nose, almost when she breathes in, everything goes in, and now we can see it. It's away from the septum, and her septum was almost clear there.
Can you feel it under the skin?
Sorry? You can feel it on the skin. That's what I'm saying, yeah. That's why you will feel it under the skin. That's not obvious. You can't see it, but you can feel it, yes. And this is around 6 months for the first patient. I can feel where is it, but I can't feel it as it was before. Anyway, I think that this is for me. I'm gonna show you the head one once we started just before going to the hands-on, so you be like a bit familiar. Thank you for this, and I think that the next will be Shadi. Yeah. So we will have like 10 minutes. Is that okay? Yeah. Maximum. So the second topics will be the suction tube dilatation. I'm gonna start with the small talks about the anatomy with Mr. Sulaiman, and then we will get Professor Alam to give us the big hit topics.
Good afternoon. Thank you for attending our course. I would like to thank Mr. Rahim and Mr. Alam for their support. So just small talk. I know anatomy is not a nice topic. So a eustachian tube, as we know, it's a tiny canal connect the nasopharynx to the middle ear. So it has very important function and complex anatomy, as well as very critical anatomical position. Firstly, described by the Bartholomeus Stricus in 1562, however, called by eustachian tube by Antonius Valsalva. Anatomy, it develops from the lateral extension of the endotherm of the first bronchial pouch laterally toward the first pharyngeal groove. The lateral extension forms the tubotympanic recess. The medial one forms the auditory tube, which is the eustachian tube. Anatomy, as we know, eustachian tube, it's tube connects the middle ear to the nasopharynx. In the adult, it's approximately 36 millimeter. So direction is anterior, inferior, and medial. Open to the nasopharynx about 125 millimeter behind the posterior end of the inferior turbinate. So there is two parts, the lateral third bony part and the medial two-thirds is the fibrocartilaginous part. The junction between both of these parts is the isthmus with the nervous part of the eustachian tube. It's shaped like hourglass with two unequal cones. The medial part is the bony part, the small part open to the middle ear through the tympanic occiput and with diameter 5 by 2 millimeter. And the long one is the mobile part. It's the long one open to the nasopharynx through the pharyngeal occiput with diameter 8 by 3 millimeter. Narrowest part is the isthmus with the junction zone form about angle about 160. Bony part, as we mentioned, it's open to the middle ear, very close to the carotid, intercarotid artery, and also to the tensor tympani. The fibrocartilaginous lays in the groove between the greater wing of the sphenoid bone and the vitreous part of the temporal bone. The eustachian tube open in the nasopharynx forms the tubal elevation. Behind it, we can see the lymphoid tissue. It's called the tubal tonsil, posterior superior to the. So yeah, superior and posterior to the tubal tonsil, we can see the Rosenmuller fossa. So the fibrocartilaginous part is the the functional part, we can do the dilatation. It's formed by the small lateral lamina, okay, and the long medial lamina. And the junction between these two lamina is the elastine hinge. And we can see anterior lateral part is the fibrous tissue, and we can see the Osman fatty bed. And this is the attachment of the tensor veli palatini and the levator veli palatini muscles. This is a histopathology picture. We can see this is the medial, the lateral lamella. This is the long medial lamella. This is the intercarotid artery, and we can see the dilator tubae muscles and lever veli palatini muscle. So lining epithelium, it's the pseudo-certified ciliated epithelium, arterial supply by the ascending pharyngeal and the middle meningeal arteries, venous branch to the pharyngeal and pterygoid venous plexus, and lymphatic drain to the retropharyngeal node. What the function of the Eustachian tube? Main one is the ventilation of the middle ear to equalize the pressure on both sides of the tympanic membrane, a clearance of the secretion of the middle ear, and protection of the middle ear by inhibiting the pathogen-leading secretion and the sounds created in the nasopharynx. Eustachian tube opened two mechanisms. Passively one, it's when any change in the pressure between the middle ear and the nasopharynx, and the active one mediated by the four muscles attached to the cartilage of the Eustachian tube. There is four muscles, tensor veli palatini, or the most important one, or dilator tubae. Second one, levator veli palatini, splingopharyngeus, and tensor tympani. Regarding the attachment, attached to the medial lamella is the tensor palatini, as you can see. Sorry, a tensor tympani. Okay, levator veli palatini and the splingopharyngeus. This is attached to the medial lamella, and attached to the lateral lamella is the tensor veli palatini, which is the most important muscle to open the Eustachian tube. What the difference between the adult and kids age of 8 and below? Regarding the length, it's shorter, it's 18 millimeter. The angle with the horizontal line, it's up to 10 degree. It's the lumen is wider in kids. The cartilage more flexible and flaccid with a less Osman fatty tissue. This is a histopathology picture. This kids with age of 3 months, adult age of 43 year. And we can see the cartilage is more thickened in the adult. Lumen is more wider in the kids with a small Osman fatty tissue. Radiology, there is no best modalities to evaluate the Eustachian tube. However, CT, MRI scan can give us good information regarding the anatomy. Dynamic imaging during the Valsalva can help to assess the function of the Eustachian tube. A 3D CT reconstruction also can help before the preoperative planning for any Eustachian tube. This is CT scan can give good details regarding the bony part of the Eustachian tube. This is CT scan, axial cut. We can see here the air cells of the mastoid. Here the middle ear. We can see the bone, the ossicles of the middle ear. This is the cochlea, and this is the bony part of the Eustachian tube. This is oblique CT scan. Patient suffering of a patulous Eustachian tube dysfunction. We can see this is here the mastoid ear cells, middle ear, ossicles, and the enlarged bony and fibrocartilaginous part of the Eustachian tube. MRI scan as well can give us good anatomical information regarding the Eustachian tube. We can see his T1 axial cuff of MRI scan. We can see this is the white triangle is the Osman fatty tissue. This is MRI scan. This is in normal position. We can see this is the fibrocartilaginous part of the Cesian tube. This is Osman fatty. This is due the Valsalva maneuver. I can see how it's enlarged the fibrocartilaginous part of the Cesian tube. 3D CT scan give us good anatomical information about the Cesian tube. This is the lateral lamella, this is medial lamella, this is the lumen of the Cesian tube, and the vital anatomical structure, V3 and internal carotid artery. Also, this is a three-dimensional reconstruction of the airspace in the temporal bone. We can see the external ear canal, mastoid ear cells, middle ear, and this is the Cesian tube. We can see the northwest part of the Cesian tube with the isthmus. So in general, we know it's very tiny tube, has very important function, very complex anatomy. It's very important to ventilate the middle ear, prevent from the sound and pathogen retrograde immigration, and also to clear the middle ear from the mucus. This is the last slide for the CT scan. So this is a patient with a left ear macrotia and atresia of the external ear canal. We can see he is very wide enlarged Cesian tube and with dehiscence internal carotid artery. This is the normal side. We can see it's a normal Cesian tube with the middle ear.
It's a scary one, yeah?
Yeah.
Sorry, we're gonna keep the questions at the end, so because we don't have much of a time. So so now is the time for the show. Where's your one? Thanks, Mr. Alam, for coming today.
Hello, everyone. Thank you for hosting me today. Actually, it's a great pleasure to be here the first time to come to Lincoln. And really, thank you. And I feel jealous of Ibrahim. You're doing a good job. It's a very educational job. And so, who doesn't know me, I'm Ahmed Alem. I'm an ENT consultant in Queen's Hospital, part of Barking Havering in London, East London. And I mainly do otology and skull base surgery. So one of the areas which I'm really fascinated about is eustachian balloon dilatation. And we are from the early centers who do eustachian balloon dilatations in the UK. So basically, we'll speak about, is really eustachian tube working or not? That's the question that everyone wants to ask. Shall we really need to, shall we do it or not? And everyone who tries, they say, no, it doesn't work. So we'll try to find out, does it really work or not? So as you know, eustachian tube, there was a nice presentation about anatomy and the role of the eustachian tube, which plays an important, crucial role in middle ear radiation. Personally, in the last few years, I think that examining the eustachian tube orifice should be a part of a normal pathology ear examination. If you have a patient who had any retraction, cholesteatoma, perforation, whatever, the eustachian tube problem could be playing the major role in why the patient having a problem in their ears. It's very, very important to look in the eustachian tube orifice. And there is a promising data in literature regarding that balloon dilatation have some sort of rules. I'm not going, I'll skip the anatomy. It have been discussed before. Eustachian tube dilatation. There is few types: obstructive, patulous, and paro-challenge induced. So obstructive, so the eustachian tube is basically obstructed. It can be physically obstructed, that you can see it's physically, so it's failure to open. Okay, either the failure to open because it's mechanically blocked by like adenoids, can be blocked with, or by just a bit of mucus, loads of mucus on the orifice of the eustachian tube can be blocked. Or functional. Sometimes there is some patients who have functional problems when they are swallowing, so the muscles are not opening the eustachian tube properly. Patulous eustachian tube, so the eustachian tube is widely open. And it's very important to differentiate. It's not that easy to differentiate between patulous eustachian tube and obstructive eustachian tube. Patients have similar symptoms, and on examination, you wouldn't find a huge difference. So you need to be very, very careful when you are choosing the patient, if I really need to do a eustachian tube dilatation or not. Paro-challenge induced, I see it a lot in my clinic. Patient comes, he say, I'm fine all the year. Once I go on a flight, I tried all the maneuvers, but once I start landing, I start having a big problem inside my ear, severe pain, and it's really blocked. It stays for a few days. My holidays are ruined. I can't go diving, but after a few weeks, 2-3 weeks, I stop and become normal. I can't fly. I hate flying. It's affecting my quality of life. That's a paro-challenge. The eustachian tube fails to open or equalize during pressure changes or barometric pressure changes. Causes of obstructive eustachian tube dilatation, eustachian tube dysfunction. So allergic rhinitis, upper respiratory tract infection, chronic rhinosinusitis, simple mucus, postnasal drip. You can see in patients, patients have postnasal drip and they have mucus in their nose. This mucus, you go inside and have a look, and there is mucus in the nose blocking the eustachian tube. This patient have eustachian tube dysfunction. Mechanical, as we said, adenoid, especially in children, nasopharyngeal masses, or scarring. You can see some scars which can be blocking or preventing the mechanical movement properly of the eustachian tube to be opened. Reflux related, laryngeal reflux, and some radiotherapy and craniofacial abnormalities. Clinical presentation, the common presentation is oral fullness, and sometimes they feel pressure, the pain. In severe cases, hearing loss. They can have a clicking, crackling, popping, autophony, especially if we're speaking about eustachian patulous. Very rare. If the patients say, well, I'm flying, or there is pressure changes, I start to have vertigo. It's not, I never see this only written in literature. Signs, number one, normal. Eustachian tube examination, you look inside the ear, the patient is normal. Have normal tympanic membrane, normal examination. But in some cases, you see the retracted tympanic membrane, and in severe cases, you will see middle ear effusions. Okay. How to diagnose? Clinically, chronicity, that it needs to be a chronic problem, triggered by air travel, diving. If the patient have some sort of allergy history, otoscopy, tympanic membrane, as we said, tympanometry. So again, tympanometry could be normal, and the patient have a station tube. But if you're lucky, you find a type C negative pressure, or even type B, you will be making a confirmation of the diagnosis. But it still can have normal tympanometry, and the patient still have the station tube dysfunction symptoms. Nasal endoscopy, we have as I said, we have a look inside station tube orifice and nasopharynx for any problems or any obvious movement. Also, when we're doing the nasal endoscopy, you ask us whether the patient to swallow, start doing Valsalva, see the station tube is opening or not, as a normal part of the examination. And as I said, a special test to do Valsalva. Toynbee maneuvers, I never done it, but it's one of the. Have you done this Toynbee before? The test. Are you okay?
Sharing, I think so. You're not sharing these screens. Yeah, it seems to be that everyone's asking for sharing screen. Sorry for the we thought that it was sharing.
Okay. Okay, when to offer a excitation balloon dilatation? When I start to think, so this patient can be a candidate. Of course, there's a questionnaire, we're going through it, and we haven't did a study about it, but roughly, if this is a chronic problem more than 3 months, we find abnormal tympanometry, impaired quality of life. This is one of the crucial things, impaired quality of life. Okay, this is what I ask my patient. They come, I feel blockage. How bad is it? How bad it's affecting your quality of life? Is it really debilitating? You get patients who used to have grommets after grommets or having T-tubes. They have normal examination, normal tympanometry, but they feel blocked all the time. And they used to have grommets that really fix their life. Failure of conservative treatment, like first we need to try medical treatment, nasal steroids, some antihistamine if they have allergy, reflux management. Of course, as we said in diagnosis, it's very clear. Patient comes to me when I have a flight problem or having aviation or pressure or barometric changes. I know that this is a station tube problem. Of course, recurrent middle ear effusion and grommet dependent on grommets. Of course, we need to exclude that this is patulous station tube, and we need to have a look inside if there is any mechanical obstruction. So yeah, we need to have a look if this is adenoid tissue or station tube. We look inside this patient. First, I need to fix his station tube and see if I will do a station balloon dilatation on the same sitting or another sitting after that. But actually, this patient, if you do the adenoids for him, you change their life just doing the adenoids. Okay, so we did a study in our department. It's around 30. We downsized it regarding the inclusion criteria to assess the outcomes of station tube dilatation in patients with recurrent obvious chronic station tube dysfunction. The study was conducted on 22 patients, for 14 unilateral, 8 bilateral ears, totally around 30 ears. Audiogram, including tympanometry, was performed for all patients. We did the EDT7 questionnaire. I will show it to you guys. This questionnaire is very important to evaluate how rough or how severe is the symptoms. There is loads of debate on literature and meetings about the EDT7 questionnaires validity. Is it really validating or showing the problem of the station tube dysfunction? But actually, they didn't come up with other tools, objective regarding the symptoms to say how severe is the symptoms.
I have it in the clinic, by the way, so it's being printed and there.
Yeah, exactly. So the EDT7, we roughly say if it's above the average of 4, more than 28, we start doing the station tube dilatation. And then we start measuring the outcomes after that. Inclusion criteria, if it's to more than 28, 28 means around moderate to severe. Chronic symptoms of obstructive eustachian tube to more than 3 months. Symptoms persist despite appropriate direct medical treatment. And inclusion minor persistent glue ear. Of course, if we find some persistent glue ear or type B or type C tympanometry, tympanogram, tympanic membrane with negative pressures on insufflation. Objective assessment of the nasopharynx and with the eustachian tube opening. Consistent history and baro challenge. Exclusion criteria, patient who have cholesteatoma, perforated eardrum, adenoid hypertrophy, chronic polyps, nasopharyngeal irradiation, all of that causes eustachian tube dysfunction. It's normal. A patient have a polyps in their nose, they will say, I feel some crackling and pressure and or fullness. Yes, that's normal because your nose problem needs to be fixed. So it's not about eustachian balloon dilatation to make his life better, it's to sort the nose, which is going to sort his eustachian tube problem. Any immunological deficiency, any anatomical cause or patulous eustachian tube dysfunction. So I'm going to explain on a video how we do that. Okay, this is so basically I do a out fracture of the inferior turbinate. Okay, I use the guide to, here it is, give me 1 second. This. Yeah, that's a nice, but I want to show something important about what I tell my trainees about.
So we can connect the camera to the what's called screen, and you can see it.
Let me see. Well, this is the opening, the orifice of the eustachian tube, okay, and this is the guide. I call this area between on the top corner of the eustachian tube as the axilla, similar to the axilla we see in the middle turbinate. I hang the guide of the eustachian balloon on the roof of the eustachian tube opening, just on the roof. I will show it to you. And then I start moving my guide slowly without any resistance, 45 degrees up in the eustachian tube until I feel resistance. So I slide this easily. There is no resistance. So easy. Then I inflate the balloon and take 2 minutes. We say silly jokes. Okay, it's the longest 2 minutes until the balloon starts working. Okay, and then after, it's really long 2 minutes. It seems simple, but it's not. Okay, and then after 2 minutes, I deflate, I come out, and here how it looks like. There will be 2 to 3 drops of blood. Don't panic. We didn't go into a false pathway. It's very, very important. Again, out fracture of the inferior turbinate. Find your, I hang it on the axilla, feel it, I push the cushions, and then push my guide wire easily. And then put the balloon again, 2 minutes. Try to be achromatic to the turbinate as much as possible. If you're doing any work in the nose, try to be do it less bleeding, so it's become easier operation for you to do the balloon. If there's loads of bleeding around and you're washing and you're trying to put some patties to decrease the bleeding, it becomes more and more difficult for you. Okay? Post-procedure follow-up was carried out 6 weeks, 6 months, 1 year after the surgery. And then we discussed the 7 items of the eustachian tube. So who's not familiar with the eustachian tube, the ETT7 questionnaire, we have 7 questions we ask the patient and we ask them to score them. So pressure inside the ears, then I ask the patient, tell me from 1 to 7, how severe is your symptom? How pressure inside your ear, if you feel pain inside the ear, if you feel clogged or underwater, ear symptoms when you have cold-sinusitis recently. This is one of the questions which is really need to be revised, and we discussed it before in meetings, that this question needs to be changed. Crackling or popping sounds inside the ear, ringing in the ear, or feeling that the hearing is muffled. And then if it's one ear or both, then we start scoring. So it's simple, start scoring, calculate, and then find the mean score. And if you see if it's on that side, so if it's from above 4 to 7, then it's moderate to severe form of eustachian tube dysfunction. And in USA, in the United States, this is the formal way where the insurance pay the hospitals if they according to the results of ATT7 questionnaire. So, and it's here NICE guidelines also they accept it. So we did so 55% were males, were 10 patients, females were 12 patients, and this is the age distribution, and this is the preoperative EDT7 questionnaires. I'm not sure if you can see that. So 82% is a pressure symptom. So most of the symptom that patient complain is the is the pressure symptoms. The patient feel pressure in their ears. Also, the crackling, feeling crackling inside the ear as well is one of the common symptoms that patients see. So preoperative, sorry. So preoperatively, the results were high, 82, 49%, 82%, 71%, 65% regarding the questions. But after 6 weeks from doing the surgery, the percentage dropped to 33, 20%, 37%, 31%, 36%, which means that the patients who, for example, had a symptom of having a scored 7 pressure inside the ear, they tell you, I'm better, but I still feel fullness. I'm around 2 or 3. And this is one of the crucial things, expectation to deal with patients. This is why people say eustachian balloon dilatation is not working all the time. Yes, because it takes time and not all the symptoms improve. You can't guarantee which symptom will improve with the patient. It's a subjective thing. You do the surgery because the patient feels pressure inside their ears. Not to fix the tympanometry, not to fix, and it's mainly the patient's symptoms. So if you are doing a surgery to improve the patient's symptoms, perception of something, it's very difficult to satisfy all patients the same way. Okay, so it's very, very important to manage the expectations of patients. And then after we measured after 6 months and then after 1 year. So as we said, so the symptoms, pressure inside the ear improved 33, then become 39, then become 42. There was after 6 weeks is better, then after 6 months started to get slightly worse, then start to stabilize. This is in most of the patients. Most of common post-operative symptoms, feeling that the ear are clogged or underwater, this sensation, was the most common post-operative symptom, still there. Least common symptom was pain inside the ear. Post-eustachian tube dilatation, significant improvement in symptoms as pressure inside the ear or muffled hearing. Least improvement is pain inside the ear in some patients. Eustachian tube dysfunction is a frequent diagnosis in otolaryngology practice, even with common diagnostic criteria. Subjective quantification of eustachian tube dysfunction usually involves the use of patient questionnaires ATT7. And there was, in the literature, they spoke about 100% that it's sensitive and 100% specific for this questionnaire. Although we still we're saying that there is doubts about it, but this is the only tool we have at the moment. And regarding the discussion, we need to that eustachian tube dysfunction is a self-limiting condition with which required no intervention in some patients. devices and as auto vent can be used in some patients. Try it. I advise my patient to try it. I'm not sure if it's going to work or not. And of course, medical treatment should be used. So we found that by evidence that there is improvement in the symptoms in the 7 symptoms when using the eustachian tube. Some studies on the balloon dilatation tuboplasty have shown that both objective and subjective improvement on the eustachian tube dysfunction measures. Subjective improvement may occur even without objective improvement, which means that the patient may feel better, although you have a C-type tympanometry for tympanogram, for example, but the patient himself after the eustachian tube, he still had the C-type, but the patient in general feels better. In simple terms, even though we don't have a perfect test to measure the eustachian tube dysfunction, patients might still feel better, subjective improvement without the corresponding measurable changes in objective matters. Thank you. And I'm inviting you. We have a endoscopic a ear surgery course, live surgery. We'll be running it on 2 days in July, so everyone is welcomed as well. Okay. Thank you very much, everyone.
What we're gonna do the demonstration for the balloon. So I need just Trishna will just give you a bit of a demo on that. How to, what is this and how we can connect this. We have the team is for us about the balloon, and Mr. Alam will show the introduction of this through the camera here. So.
Yeah. So do you want me to just talk through it and then Mr. Alam can demonstrate?
Yes.
Yeah. Okay, no problem. Hi everyone, my name's Trishna. I'm from Stryker. So this is Audion. I think some of you may have heard of express balloon dilation. Now, express is our version of balloon dilation for the sinuses and the eustachian tube. However, Audion is our newest product, which can be used solely for the eustachian tube. It's a very, very simple device to use. So when you receive it in theatres, you'll have the device itself, you'll have the tubing, and then you'll have the inflation device. The key difference between Express and Audion is that it has a locking mechanism. So as Mr. Alam was saying, 2 minutes can feel like a long time, especially for the scrub nurses, because they're having to hold it down for 2 minutes, but now it has a locking mechanism, so it just makes it a lot easier, and it holds it at the correct pressure for the full 2 minutes. So it works very, very well. In terms of setting up the device, all you have to do is attach the tubing to the inflation device. Then you have to hold it upside down and make sure that the other end of it is in the saline, and then you have to, I would say 3 times, I would fill the syringe and empty it 3 times. And the only reason we say that is because you want to limit the number of air bubbles inside the tubing. Okay? Haven't actually got the locking mechanism with me, but you would attach this end to the locking mechanism and then to the actual device itself. And then that's ready to use. This white button here, so when you are in the eustachian tube, you will extend that, and that's when you're ready to dilate for 2 minutes. Does that make sense? Any questions? Yeah, very, very easy to use.
Sounds good. Okay.
Did you want me to get some water? That's you're used to using Express, aren't you?
Yeah, exactly.
Do you want to use Express?
You have the Express?
I do. Yeah. So that's the new one, Audion. Okay, I'll give you that one then.
Excuse me, Mr. Alam, just,
Yes.
I mean, if you have an obstructed type tube,
Yeah.
is there a danger of changing that to a bacillus?
No, I'm not changing it to the back.
No, that's what I'm saying. Is that a risk you need to inform the
No,
patient about?
no, it's rarely. I've never seen it. Okay.
All right.
I've never seen it. Patulous station tube happens when the fat starts to debilitate. And it's mainly the most common thing. You can see it in patients who lose weight quickly.
So it's not a
But
risk
not
we
the
have to-
crushing, because the idea of a balloon dilatation, by the way, I didn't say that, is that we crush the cartilage and then start to fibrose and give a 1 or 2 millimeters, which you already need. That's all. That's all we need. 2 or 3 millimeters to open and to allow the air to go in and out. It doesn't cause a vascular suspicion.
Okay, so Mr. Alam is used to using Express, which is what I spoke to you about earlier. So with Express, you get this device. So when you take it out of the box, it comes bent to go into the frontal sinus, as you can see there. However, if you want to go into the eustachian tube, you've got the eustachian tube dimensions there. So you would just place it into here, and then you would just bend the tip accordingly.
Yeah, so I need to follow this So,
Okay.
so now we're gonna do the just the anatomy round, and then we can get.
Okay, we don't have any. So it's basically, guys. So again, this is. It should be on the same angle of the station tube, which is 45 degrees. Okay, so basically, this is the normal. You can see this. This is the nose. Okay, this is. Let me see this. I'll just use it for some anatomy. This is the inferior turbinate, this is the middle turbinate, and down here is the opening of the eustachian tube, okay? So simple. There is multiple ways to do it. You can use a 0 degree or a 30 degree. In some centers, they can use a 70 degrees from the other side, or 45 degree from the other side and do it. Whatever the mean is, whatever it makes you comfortable, use it. I personally use a 0 degree. So I go in facing down, okay? Okay, and then I feel, you see the edge here? You see the top edge here? I feel it, push, and then go inside. Of course, this is not as natural. And then after you go through the two sign, you start pushing it in. Not sure if it's going to go in there. Is this designed to go in?
Yeah,
It is,
yeah, it is.
Yeah, it should go. You just need to apply a bit of force because of the material.
Don't do this in real life, no, okay? Don't do this at home. So if there is any force, don't try to force it. You'll fall a false pathway. And then the patient, you did the dilatation, the patient wakes up, you have surgical emphysema, okay, with the first cough. Did we see it? We saw it, okay? So the less pressure, it's go with the natural flow of the eustachian tube. You're just dilating the eustachian tube. You don't want to do much injury. And then you start inflating it, and then after you finish, you withdraw this out. Well, it's fine. We can do this when we are.
Then this is the pushing, and this is the back. So this
Yeah.
is to advance in the balloon and to get it out. So once the trachea and the lead is in, you just push the balloon in, and then inflate.
And then
And then once you out, it's been deflated, just push it back.
and then you go out, you pull, and then again we'll shift this out and go out. Okay, so touch this, touch the edge as I said, go up, You see, I'm turning. Once I hang this on the top here, I'm turning the edge and then go smoothly.
Until you get this, you can see.
Two.
You can see here is the mark.
Yeah,
So
exactly.
once it's there, he will advance the balloon. So now Salam just push the balloon in.
Yeah. And
So
then
you want to make sure that you go to the 2 lines, which marks 2 centimeters.
okay.
And then once you advanced, I will just put this in. We don't have we can get the connection anyway, but on the once the water comes out, hopefully
It's coming.
okay.
You still push to the end.
Push to the end. It's to the end, but it seems to be that is it leaky?
Oh no, you've got the wrong one.
Oh.
Oh no, you haven't.
Anyone thinks
No, you've got the right one.
the right one, yeah?
Oh, you didn't. You need to fill it in.
Is it filled up? Sorry.
Is it filled?
Yeah, should. Yeah, it should be. But simply, it's
I think it's.
this leaking the balloon itself. It's
Is it leaking?
Yeah.
Through the tubing because
Yeah.
you've used it so many times.
too many times.
Okay.
Anyway, so and that's it. To wait for the 2 minutes. I'm gonna deflate. Take this out. Yeah, and then go back.
And the trick here is to pull it out. So it's not that easy. You see, to pull it out and then move again slowly. Atraumatic. I see the edge with my camera. I see my edge. I'm not pulling it roughly. I'm not touching the turbinates. I'm very gentle going out. And then bye-bye. Okay? Let's see if we can do
That's
it,
fine.
everyone.
Yeah.
Okay?
I will show you the implant as well. How we set up the implant. So
Same. You want to do this with the other one as well?
We can do this one.
So this is with the new one, which have the, you can need to pull the deflate.
Yeah, if you just pull it back.
Pull it back. Yeah.
So, okay.
I've already deflated.
No,
So-
it's not deflated.
Okay,
It's,
you can push it. It seems
Yeah,
to
you
be.
need to just
Have
pull
it.
it. No,
I'll
pull it
pull
back,
it.
fully.
I'll pull it.
Do you want me to?
No, I'll pull it fully.
No, yeah. Have you pulled it back? Yeah.
no, it's not it's here deflated. Yeah.
Yeah.
Okay. So again, same principle. You go in, feel the edge.
That's it. Because it's the model is not that easy. It's not that slippy.
Mhm. Again, feel the edge and then
Push advanced.
advance in. That's why I'm telling the other one is better. It's already deflated. That's why.
Yeah. Okay.
Okay. And then push out.
Push. I should-
Deflate.
You can see it now.
Yeah.
And I can. I'm pushing it for
2 minutes.
2 minutes. And you can feel the resistance here as well. And you can also on the camera here, you can see that this is the dilatation is happening.
Okay.
And then deflate.
And then again turn around
Disadvance.
and then come out. Okay. Any question?
Do you do it under local or general?
I did it. I did a couple of patients on the local, but I didn't theater because the guy still there's some waiting sometimes, and the clinic setting they get scared. So, but you still can do it under local, and the patient was happy.
If some of the patients probably will not be happy afterwards, do you offer grommets after an unsuccessful dilatation?
That's the thing. Well, I define by patients patients who already have a problem in the nasopharynx. I consider them the easy one, and this is when I'm really happy. Patients who are having a normal examination, normal tympanometry, normal hearing, still it's not very indicated to do the investigation during dilatation. Then we discuss the symptoms, how severe. You really need to do that, and then lower. Well, it's not lowering their expectation, but say the reality. It's not going to fix the problem completely. If it fixes, good. You've got a box of chocolate. That's fine. But if
Model. So I have my patient.
sorry. But yeah, if I offer them, if they still have the symptoms, I still can offer them the promise. Sometimes I do myringotomy in their ear. Let them go home a couple of days and see if they feel the pressure symptoms. Do a small myringotomy in the clinic without doing anything. See if this is improving, going to improve the symptoms of it's going to improve. Sometimes they offer promising. Yeah, and sometimes you can repeat that. It depends really how much the symptoms and case by case. Station tube dysfunction is case by case. Yeah.
The balloon dilatation, the balloon reaches the bony part as well, or only?
No, it's mainly on the cartilaginous part. The aim of the balloon is to crush the cartilage. Crushing the cartilage, initiate inflammatory reaction, cause a bit of a scarring, cause a bit of dilatation. That's why we measure it after 6 weeks, 6 months, 1 year, and see how much improvement.
Is it mandatory to do CT scan before dilatation or not?
No, usually it's not a routine thing. It will be extra investigation that's not going to add anything. You know, the images that you have shown about CT scan, you're lucky to have this type of scans. If you order a CT scan temporal on how many you can see, you can really assess the station tube as a whole. So it's not going to make a huge difference in your management as well. That's the problem with the station tube dilatation. That's why not many people are really happy with it, because station tube is a very subjective. It's not a one-to-one. It's not a tympanoplasty. You put a patch and the patient, the neck membrane is closed. It's very subjective, and it differs one person. Each patient is a case by its own.
So what's common complication for this?
Common complication, bleeding, as well as that's the thing, bleeding. Very rare. If you did it in a bacterial station tube, you didn't diagnose it, you make it worse. Okay. And as well as surgical emphysema. Theoretically, also there is a risk for the carotid, but it's not much. But it's surgical emphysema we saw a couple of patients. Not this one, but another one. Yeah.
The 2 minutes that you dilate, is there any role for increasing or decreasing depending on the ETD questionnaire score? Has anyone looked into this?
You mean how much the pressure that you need to, according to the score? Well, that's the thing. The score is a very subjective thing, okay? And it's not very solid. That's the problem with the score, the ETT7 question. It's very subjective. If you sit with a patient, you did it in the clinic, ask them, how do they feel pressure? 5, 6. 7, make it 7. You know, this type of, it's very subjective. So you can't say you want to make a subjective thing into a physical objective thing. It's really difficult. So I know what you mean. So his question is, if the patient have milder symptoms, shall I dilate it with a less pressure? And the patient have more symptoms or severe scoring, I can give them more pressure. It's not, and it's measured. The pressure inside is measured to crush enough pressure to crush the cartilage to cause the fibrous reaction and cause the dilatation. Okay.
So the balloon will always maintain at 12 atmospheres.
Exactly.
Thank you very much for your talk.
Yeah, thank you.
In considering exclusions, how much weight do you put on those who have persistent habits like heavy smokers and they're not happy to stop smoking? Would you consider that an exclusion or not?
Oh, well, that's very rough. It's something that we say that smoking is the cause of your nasal problem, and your nasal problem is the cause of your. Still, if you did the turbid surgery for this patient, for example, their symptoms will improve even if they are smoking and not smoking. So to have a direct link between smoking and the station tube dilatation, there's no true evidence. Yes, theoretically, it causes nasal congestion most time, causes nasal affection, and in theory, this is going to increase the mucus, and by theory, going to cause a little bit more of station tube dysfunction. That's true, but it's not the true evidence, that's solid evidence that this is the cause of the problem.
Thank you. Secondly, you said in considering exclusion, if patient has reflux, laryngopharyngeal reflux disease.
I try with the medical treatment first.
Yeah. So what if, for instance, they've been reasonably well treated for the laryngopharyngeal reflux and they don't have symptoms of laryngopharyngeal reflux? Would you still consider that a contraindication? You will go ahead and
You mean silent reflux, you mean?
Yeah, silent reflux. They've been treated and their reflux symptoms have abated recently. Would you be happy to proceed?
Well, again, I didn't mention in the test that there is in order to say that there is only the reflux is the cause of the eustachian tube dysfunction, you need to have a pH manometry for 24 hours in the nasopharynx, and then we say that this is the real cause of the eustachian tube dysfunction. No, it doesn't work like that. In theory, and it's part of the factors that causes nasal eustachian tube dysfunction is the irritation caused by the surrounding organs. One of them is the nose, and one of them is the reflux as well. That's why you give the patient nasal treatment as well as anti-reflux treatment, and see if this is going to help with the symptoms or not. If this started to help, I put the patient on anti-reflux treatment, and the symptoms started to improve. So in theory, that the reflux is the cause of their eustachian tube dysfunction, and then I advise them to have gastroenterology, to start to continue on the anti-reflux treatment for a bit. But if it didn't work for them, okay, so it's not, I wouldn't argue all the time that this is the reflux is the cause of the problem, and I would proceed if I can do the eustachian tube dilatation according to the rest of the criteria.
Okay.
Can we repeat the procedure of the symptoms?
Yes, you can. If the patient have improvement after 6 weeks, they feel better and then start getting worse, and then you can give them another session, but it's not as a rule.
It depends on the symptoms.
And the symptoms of the patient improvement. So some patients say, I didn't get anything, I didn't feel anything. So I don't think I'm going to do it to them again. Some patients say, I felt improvement. This is the ones who really I offer them a second one. I'm really I offer a second one. But it's still. Anything else?
Is there any tip to differentiate eustachian dysfunction apart from autotomy?
Well, there is. If you're lucky, if a patient passive eustachian tube, if you're lucky and the patient start to have the typical symptoms of feeling that the air pressure changes, air going in and out while they're breathing, you'll be really lucky about it. Careful history as well, feeling, but to be honest, it's really difficult. It's really difficult. And I got a patient who had and I'm following this mistake, and everyone follows this mistake. You do dilatation and the patient have autotomy. But if you can start suspecting it if the patient is, especially a patient who lost weight recently, patient or in the last few years, or patients who have they feel that the air going in and out, it's a pressure all the time. Valsalva doesn't make a huge difference in their symptoms. This can you start have a red flag. Anything else?
We have done it for a glue EO type B. Do you do it for type B?
Not as a well. That's a tricky question. We had this discussion before. If a patient have a glue ear, okay.
Usually adults, so you don't have a glue ear. It's more serious.
Because eustachian tube takes time. So the idea, if I do ballooning, and I do crushing, and I wait for it to heal, the patient still wake up and feeling blocked. So I still do a merivotomy. I still put a vomit sometimes in some patients. I know it's very debatable. It's very debatable. You're doing 2 procedures in the same patient.
Which is the what's make the patients better?
Well, it makes me out, but I personally feel that I do a grommet for the patient because this is an immediate effect. This is a table improvement. The patient wakes up, the fluid is gone, they feel better, okay? But the grommet stays for 6 months, 6 months to up to 2 years sometimes. So I still do the balloon dilatation.
We don't have the same experience with you because it's new for us, but the 2 patients that we have, it was type C, type B. And surprisingly, after 6 weeks, the type C become type A and the type B become type C, and both of them. One of them, she is very happy because both of them are ladies, so you cannot please the ladies always. Yeah. So one of them was very nice, and she was appreciating what's happening. The other one is saying that still I can feel the symptoms in the ears. I said that totally it's different. It was B, it becomes C, and now you have a good ear.
If you speak with this patient, so if you do the questionnaire with her, okay?
Yeah, I know.
And then you go and you find the score's really good, and then you tell her, listen, you told me that this score was.
She would change it.
Now you're saying 2 or 3.
She would change it.
Yes, and then listen, so smiling from my face. I did something. I did a good job for you, you know. So this is what I told her.
I will bring it to talk to her. I'll send it to you. Anyway, thank you everyone. So the next one is a bit need a bit of a concentration, especially for the team, because how to load the implants and do the implants, and then we'll go for the hands-on. So hopefully this will take a few minutes with us. It's not that big, it's 10 minutes, but
I'm going to do a demonstration of Latera on the head model. So I have my patient here, Mr. Smith, and Dr. has prepped the Mayo stand with everything that we need: a marking pen, the Latera positioning guide, a forceps with smooth tips, the Latera delivery device, the Latera implant tray that contains the 2 implants, a double prong skin hook with sharp prongs, and an injection needle. So first of all, Latera is done mostly concomitantly with septoturbs, and Latera always will be the last procedure done after all the packing and so forth. The first step is you want to make sure that you prep the exterior of the nose with betadine, just in case of buttonholing. So prep the nose. The second thing that you'll want to do is start your planning, the 4 Ps. The first step is plan. So with that, I will pick up my positioning guide. I will pick up my marking pen. I will want to mark the alar rim, superalar crease. So superalar crease is right here. I will feel for the caudal aspect of the nasal bone. Mark the nasal bone. And then position my positioning guide over the anatomy. I will want to be cephalic to the superalar crease by 1 millimeter or 2, parallel to the dorsum, and the distal forks will be over the nasal bone, mid-radix, mid-medial canthus. So this position looks right here, good right here. I will make 3 marks. So my distal mark, my proximal mark, trying to increase these dots. And I'll place a 3rd mark on the rim of the ala in line with my other 2 marks.
So this one, he started with the marking on the lateral side than the outer side. I found that it's better to mark the lower, your lower marks, because it's the midway from the tip to the ala, so it's easier, and then go for the other one on the same level. So this will be the level of the injection, and everything is there. So it's just a different way of where you're gonna mark, and the same thing. It's just above the lower lateral cartilage and the alar side, which is the soft tissue here. They usually collapse, and it's the junction between the lower lateral and the upper lateral. So this is the edge of the bone, so you can feel the bone, and then he puts these marks in between, as I said, supporting that side on the bone, and the other one is just on the alar.
And that will guide me towards my pierce point. From there, I'll put down the positioning guide and marking pen. Now we're going to want to inject. So I will take my injection syringe with my lidocaine epinephrine. I will inject up the track to my distal mark with a 27 gauge needle and inject a 0.5 cc as I withdraw through the track. Perfect. From there, we're going to want to load our device. So I have the delivery device here on the Mayo stand, the implant tray here. So I will press the back button to open the delivery device as I pull back on the outer handle, making sure that the outer handle is behind the gray line here, which indicates my push rod is out of my implant loading port. The implant tray I will open. I will want to make sure these are aligned, Latera and Latera, so that way the distal forks are oriented towards the cannula. I will take my smooth forceps pickups, play the game of operation and drop the implant into the loading port. Make sure it's fully seated. And then advance the outer handle forward as I watch the implant advance into the cannula until I hear an audible click, and then I know the device is ready. I'll also close my implant tray lid to protect that second implant for the other side. So at this point, I'm ready. Notice when I load it, I kept everything on the Mayo stand instead of picking it up to avoid dropping the implant. So I have my markings. I have my delivery device. I'm ready. At this point, I will uncap the safety cap on my delivery device. I will pick up my double prong skin hook. I will span my mark with the double prong skin hook. I will position my hands down low and put pressure against the back of the ala to get a firm grip on the double prong skin hook and evert the ala. At this point, I'll be ready for the second P, pierce. I'll take my delivery device. I will position the delivery device with the bevel towards the septum, which means the Latera logo is lateral to the patient. So with the bevel towards the septum, my pierce point is going to be caudal in the vestibular lining. So in the head model here, you have the rim of the ala, which is the silicone portion. So this is the bulge. You have the color transition to the skin, and just where it starts, the pinkish skin color is the vestibular lining. So caudal in the vestibular lining would be pierce point right here. So you're going to pierce perpendicular, almost 90 degrees to the septum. You can see the angle I have is towards the septum. So I'm gonna pierce, and I'm gonna pierce and plane thin to the vestibular lining. So you can see that bulge of the vestibular lining. So my bevel's disappeared a few millimeters. I'm gonna make the
Make sure you're not passing the cartilage, okay? Because otherwise we'll be above the cartilage, and this is what we don't want to.
Is it medial to the cartilage or lateral?
Yeah, medial to the cartilage.
So it's between the mucosa and the cartilage.
It's yes, you can say that it's the skin of the vestibule, because still you're gonna pierce the skin. You're not yet into the mucosa. It will be later to the mucosa.
So it's going in the mucosa between the lower lateral cartilage.
Yes.
And then when you turn it on,
yeah,
you go between the lower lateral and the upper lateral. So you become lateral to the upper lateral cartilage.
Yes.
And then below the skin, then you go on the
turn to plane up the lateral wall. So I'm going to keep that counter traction with my double prong skin hooks, pulling back, and I'm going to slowly advance the cannula. So this should be pushing the cannula, like pushing the cannula through butter. Every now and then I'm going to lateralize to see where my needle's at. I'm going to continue to advance.
And you can see the direction of those forks is the same direction of the skin of the vestibule. Okay, so those are the leads for yourself. Do not make it more rotatory inward or lateral, because this will make the position of your implant is in incorrect position. Okay, so make sure that those forks are the same line with the vestibule lines, which is the main curve of your nose.
I feel the nasal bone right here, so that means I know exactly where the tip of my cannula is. So that's a good anatomical orientation or marker. So I can push the bevel and glide it right up over the nasal bone. Continue pushing to my distal mark. So lateralize, I can palpate, feel them right on that distal mark. So that is the completion of the plane. I will drop my double prong skin hooks. At this point, we're ready for the third P. So that is push. So there's two things that we need to check here. We need to check that the fork orientation features are parallel to the nasal bone. And the second thing is that we need to check that the orientation of the device, this angle, is parallel to the nasal bone. Another way that I like to look at this is, for training purposes, is the positioning guide. So the angle of the lateral wall is always slightly different than the angle of the nasal bone. You take your positioning guide and put the distal in and hold it against the nasal bone. That gives you the angle that your device should be at the point of deployment. So you can align your device with being parallel to the nasal bone. So that's a good position right here. So I'm ready to deploy. So I will support the nose cone gently with my left hand. I will push the deploy button with my right thumb, and I will advance my right hand forward till I hear an audible click. Click. So deployed. So I will gently support the distal forks, which is right above my distal mark, with my finger, and I will pull back the delivery device in the same plane that I entered in. Perfect. So I'll put that down. So next we want to confirm that the implant is in the proper position and it didn't pull back when we retracted the device. I'll insert my finger in the nasal seal. I will feel for the proximal ball tip. I do not feel anything, which means the proximal ball tip remained above or cephalic to the alar crease. And Mr. Smith is breathing better. Thank you.
Any questions?
So it's lateral to the upper lateral cartilage and the lateral to the nasal bone.
Yeah, and you can feel it out in the outer part there. I haven't seen it, but if you have a very thin skin and very blondie, maybe, but and it's transparent, so I don't think that you can see it.
My understanding that you use it for a collapsed lower lateral cartilage.
Yes.
And in the last sentence, you say remain cephalic.
Yes.
To the lateral.
So this is the if you see it here.
The collapse is the lateral cross.
Yes, I know. So you see it here. There's 2 points there, so the 2 circles there.
Yes.
Okay. So those 2 circles should be lateral, but this will be almost touching the lower lateral column. Okay, and that's why.
I see. Okay. Okay. So basically, it's taking the cephalic part out.
Little bit. Yeah, that's why we put it medial or into the mucosa on that side, and more lateral when you go outside with the upper lateral cartilage.
What is your feeling, and how would you know that you are lateral to the upper lateral cartilage? I mean, apart from the fact that you are manipulating and moving right and left, stretching and flexing. So you might be risking that you are in the cartilage itself, isn't it?
No, there is. If you inject it well, and you've seen the upper lateral and the lower lateral a lot with the rhinoplasty, so it's like the same like what I'm saying, that if you're doing open rhinoplasty and closed rhinoplasty, it's the same. You know where you put the scissors, and you can know where you
do an intercartilaginous incision. We can see the lower edge of the.
But you dissect usually blind because you know where you are. It's the same feeling. So.
Right. Okay.
Excuse me, why do we need to go perpendicular towards the septum first? I don't get this bit, because I imagine that if we just go lateral, because we aim to go lateral. So.
Now, what here's was eventually is that we're gonna have hands on anyway. Okay. So the point is that you can't go this way because you may go through the cartilage. So the best is to go that, pushing with the hook. You would do it, and just be very medial on the mucosa. Once you find that you pass the lower lateral, you advance and rotate and become more towards the upper lateral cartilage. That's what you do. So the right angle is only when you introduce and then you go around to get out. So the lower bit is your medial, the upper bit your lateral.
Thank you.
So we're going to have the hands-ons, we're going to divide ourselves into two groups. I'll be Tricia on that side. We have some drinks also from Oliver from Servants. They have their own balloons, but we haven't used it there before. Also, they supply with a lot of disposable scissors and other things.
Really?
Yeah, a lot of stuff as well. So thank you for that. So we can enjoy some soft drink first, and then we're gonna divide ourselves into two groups. So please, we have our nursing team as well, so you can divide yourself into two groups. Is that okay? I would say that the first right to the first balloon, and the left team were the is that okay?
Actually, all of them. Actually, all of them go for
I still got like another 3 wedges.
Now everyone, make sure you close your eyes. But actually, to be honest, one of them is this is the new one. Yes, absolutely. So, you know, when patients they have a small plastic this will be the ET. I don't even see. Put it there. And there it is. Just make sure that the unit or application yes, you get the careful. This is for the old one. You will find that one. This more the big. And the best thing in it, you can use it for frontal. If you want to go for frontal, you have to go maxillary as well. The new one is already yes. But one thing that you have so we have everything else, right? No problem. Connection. As mentioned, you need to get the air first, make sure that you get it in and out. Anyway, it's not an issue. And then with connection, so it's very easy. Push this to that, the air, and you can do the person. Push this yes. On the pressure team for yourself. Okay, guys, okay. Your you need to put it all the time that your camera is above. Yes. Okay. Don't be in between.
Yeah, we do January.
So I had surgery back unfortunately it's not happened until it's come.
There's a loop we can use to see first one. Start.
No, you can get a tiny bit of feeding. So what you need to do is, so you're holding it like this.
So usually, there's the balloon. So you need to go back again out, and you need to be above the balloon.
Yes.
Okay.
Sometimes if you start to see the hawks hanging out. Yeah, so just check there. Yeah, you can feel it. So what you're doing is you're just pressing down just to make sure that it doesn't relax.
We've got that express and we haven't got an audio on the shelf. Yeah, I've never used it yet. I've never used it, but I think you actually and you've got that for Latera as well. We are using Latera already actually. The loader and the
هو ما في ولا ماسك هو نشتغلوه يعني دبل
What is that? That is so good.
This is the microphone. Yeah, no,
Really, really good.
save the time.
For sure. Did you get it doing? Do you kind of plastics? One of the plastics guys was asking about this in Newfields this week. It was actually some of the chat he was getting back was quite good. Is it free? I think it's free, isn't it? Yeah, that's what I thought. Yeah, it's very good.
It's not
People were twitching about it, right?
all of them are fighting now. It's the people.
You can ask it to do projects for you with ChatGPT.
Yes, yeah.
And you can leave it to do it while you go off and do other things, which is quite good.
It's a nice.
I saw that and I was impressed. It's very well set up.
Yeah.
Very good.
I'm interested anyway. I'm starting to lose my interest. Yeah. You have like courses like this. People are not talking about resistance rates. I think so. They used to pay for everything. Should be free.
Education should be free.
All of the education should be technology is a service that should be free.
Oh, thank you.
How many things do you do? Dilatation, two dilatations, and lateral laser implants. Just one.
Laser one.
Surgical cases. How many patients do you think these two technologies?
Only 6 months. We don't have that much. We have a lot waiting list now. But some discussions, they have more material. It's good.
Is this snoring or
لا مليون
Yeah, but this is the thing you need it from the top.
That's a key example.
ايه هذا اللي عمره انا لا انا اللي عملت له دشار
They don't like the local. No, they don't look for the local implementation. But I used to work for it local.
هلا هيك عم بيصير
I have hundreds of them. I've done one or two now. Done convey.
دائما لا 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 دائما هلا هيك عم بيصير بياخذوه بيلاقوه فوق بيرجعوا
One go, 85 mask weight, all of them local. Correct. Yeah, I've been to it's even I used to do it in private. I pay 1/4 of my work. Yeah.
On Instagram.
That is really helpful to make that decision. Yes,
No, there's inflammation and infection, contaminated area, and we need corticosteroid. Usually, it's over the I'm not sure he in UK. Oh, she was trying that. No corticosteroids.
Bothering me on a daily basis.
He needs the double flat. That is your radiotherapy. No, it's they done it. Already discussed with Mr. Stark if they when he will be credited 16. Yeah, I hope that's on.
We have
Yeah, so just make sure.
Oncology, but they can't take the patients in surgical
That's very bad. And you know already.
I don't know if you're going to be able to get
already there, so I have the negative fungal, which is trying to improve. I have multiple chairs, and that's fine because I have two hands. I have only one hand. Not only it's broken very easily. It's put it in the wrong way. It's not fixed now. Yeah, without it, it goes to the right place, and even if it's the way, just around it. You don't need to turn it on. And I still, you have it with you still have it with the companies used just the cat wire. Yeah, amazing. There's no complication.
I'm just kidding. No. I was feeling this you just that's why
Those are the best. For me, still the Miguel one. Miguel. This is very simple and usable. Easy and the simple and the easiest to flip. Yeah. And it doesn't have more complicated shapes.
All of our members, like me, all the patients can see it.
I know it's like
apparently the
The ear one would be and like nasal. Yes. I think
She had like
thyroid, yeah, and tonsillectomy. And what is this? Thyroid and like main neck yeah, I saw that. That's the wrong. I've had it with the small collection in Australia. تقريبا 1
I couldn't say no.
How are you?
Did you drive or?
Yeah, we've tried that one.
Oh, right, okay, okay.
Yeah. Have you had to go? Have you ever done this operation before?
I have done it in Nottingham.
Wow.
I think it's coming up here.
Okay, fair enough. You need your
So,
charger, right?
who is on call here? Who is on call?
Anna, she stayed because she was in theaters. She said she didn't want to rush, so she stayed. Yeah.
I think the theater was late. Yeah.
We're gonna meet you on Friday.
And then who is laid on call? Ashraf? Ashraf?
No, no one is on call. No one. We just hold it. Yeah.
Second one, I don't have anyone.
But we
I don't have anyone. Sestina and you.
But what for, Mr. Swaji? Okay.
We were just transferring the calls to Lincoln. So she has missed this teaching just to transfer calls to Lincoln. Anyway.
So you are going back now or?
Yeah? Well, not still Christian. We're going home. Lord is taking a train. I'll travel back.
All right. I'll see you tomorrow.
All right. You're
I'm there in Boston tomorrow. Theater.
I'm on.
Michael or yeah. Very good. Enjoy it here.
Thank you. Yeah, nice. First time on Lincoln.
All right. I think July we are doing the another course as well. June we don't have. June we have the audit. And then July we have tracheostomy and the laryngoscopy as well.
Yeah, I guess we will come. Hopefully it's before you leave. Yeah.
ممكن ككونسلت ان هو المشكله هنا بيعملوا كنترول ومنتال يا باشا طول الوقت بيس مين ده بيس بيس فيري هارد
عالم جديد، عالم بتتدلع، عالم بتتدلع. بيعملوا 3 ايام نايس ياخدوا عليها هم عايزين بس وبعدين لحد يوم بيتي عشان بيطلعوا ولو رحت ما
ايوه بالظبط ما
عشان انا اجي دلوقتي كده وانا 10 ما عنديش مشكله.
انا مره كنت بقول له اجي مع حضرتك قال لي لا ما ينفعش
هو دلوقتي عايز
مين اللي هيسمع؟
ما اعرفش. وبعدين الحاله
في حد هناك لحظه بس مش في حد هناك بيحاولوا عليه هنقول افتر 5 مستر سلم عايز حد EMT معاه اللي هو انجلش مش حد
Thank you for listening. So I'll speak with him again because he was just preparing himself back to Pilgrim. So I'll let him go. Yeah, thank you. Thank you.
هيدخلوها على سيف.
بص هم خدوا القرار.
طب خلاص معاك حاجه
لا الورد انا وصلت
مش مشكله الرول اهم حاجه في حاجه ارجنت هاجي انا عليها
لا مفيش حاجه مفيش حاجه
معلش انا كنت بقرا على حضرتك على الفيس بس والله فعلا مش لاقي حد كلمت ضيف اجازه شاكي
مصيبة أنا شادي؟
انا هشوف الايام بتاعتك كده لان انا برضه ليدي بتاعي كذا مش موجود انا هاخد اي يوم تاني 4 او 5
أنا عملت كده
Yeah, so that's why I always say if you just let me know when you've got your first patient, I'll come and see you for a couple of patients. I think I've actually got your number. So I'll just drop you, or I'll ring you, and then what we